My name is Conor Judge. I'm a consultant nephrologist working inside the hospital for half my time looking after patients, and a senior lecturer in applied clinical data analytics working at the university for the other half. So today I'm going to talk about how to test artificial intelligence interventions in pragmatic trials. So for this presentation, I'm wearing a few hats. I did my higher specialist training and trained as a nephrologist. As mentioned, I'm an electronic and computer engineer, and my aim was to always bridge the gap between the two. During my higher specialist training with the HRB ICAT program, I did a PhD in epidemiology and biostats, supervised by Professor Martin O'Donnell, who many people will know, and Professor Martin O'Halloran. So I'm currently funded by the HRB as a clinician scientist to develop an AI clinical decision support system for hypertension. And I'll talk about that in a second. And then in my spare time, I'm a co-director of the Masters in Applied Clinical Data Analytics. And if we have enough time, we can briefly talk about that in the end. So the patient journey for the AI clinical decision support system for hypertension is, starting on the left-hand side, the patient comes to the primary care physician. All of the information about the patient is entered into the electronic health record. So this will include their past medical history, the medications they're on, their blood test results, what happened at the last visit, and what's happening at the current visit. All of that information is passed into the AI clinical decision support system. It's pre-processed to put in a form that can be passed into a neural network that we've trained on the SPRINT trial. Many people in the room will have heard of the SPRINT trial. It was a US hypertension trial that randomized patients to a blood pressure target of less than 120 millimeters of mercury, or a blood pressure target of less than 140 millimeters of mercury. There was not 9,500 patients in that study, but it represented 140,000 times that a patient sat in front of a SPRINT investigator, and the SPRINT investigator took all of the information about them, their baseline, their between visits, their at visit, and they made a very nuanced decision about what the next best antihypertensive for that patient is. So this is what we wanted to learn. This is what we wanted to package up and put that expertise in the hands of the primary care physicians. So the AI clinical decision support system will make a recommendation, but it's the ultimate control of the primary care physician to take that recommendation or not. So as part of the HRB grant, we're doing further development on the model and external validation in another trial called the Accord trial, and in real world data with the UK Biobank. What's very important here, though, is will this be trusted and will this be acceptable? So we have some human factors work packages around this. We're currently doing a survey of 600 patients and physicians about their perceptions of the use of AI for clinical decision making for hypertension. We're also doing user-centered design experiments. How do we present the information in a way that the physician can make a meaningful treatment decision on? And we have a strong public and patient involvement group as well that guide us on every step of this journey. At the moment, as part of that grant, we're doing a prospective comparative evaluation. This is taking hypertension scenarios, so patients recruited from the HRB primary care clinical trials network, presenting them to our AI model back in our lab, and to record the recommendation. Then take that same scenario and present it to a gold standard panel of experts. So this is an expert in hypertension, as a nephrologist, as an endocrinologist, and a primary care physician. So this is the bar that the FDA requires at the moment to approve an AI clinical decision support system. But we think this bar is actually quite low, and we want to go further than this. So the question I pose is, what is needed to ensure that AI in healthcare is safe? So I presented this slide at the Irish Medical Association, their annual general meeting a few months ago. And I told them that AI in healthcare, you can just replace that with the word medication. And now the question is, what is needed to ensure that medications in healthcare are safe? And then the answers are very clear. So this is what we must do. We must test and treat the AI interventions with the same rigor we do with medicinal products. And the answer here is randomized clinical trials. And I don't need to explain to anyone in this audience how a randomized clinical trial works. But sometimes it's good to think about what a randomized clinical trial for an AI intervention looks like. So we know for a medicinal product, for a medication, a patient comes into a trial and they're randomized to an intervention group or a control group. And the beauty of randomization, or the magic of randomization, is it creates two equal groups on average for all the measured and unmeasured confounders. Then the groups receive the intervention or receive a placebo, and you follow them up in time and you count the outcomes. And if there's a difference in the outcomes, well, then there's a causal association between the medicine and the outcome. So now, if we think about AI in this case, what will happen after randomization is the patient will be randomized to a pathway that includes an AI intervention. So this could be a computer vision model that reads a chest X-ray, creates support. This could be a large language model based treatment recommendation, or this could be an AI clinical decision support system for hypertension. You follow them up in time, you count the outcomes, and if there's a difference in the outcomes, you know there's a causal association with a pathway including AI and the outcome. So the research vision here is that the same way we test potential new medications with preclinical research, phase 1, 2, and 3 clinical trials before being approved, we must treat potential new AI models with the same rigor. And there's a huge gap here. The figure on the left is the number of AI publications in healthcare, and if you look at the scale right on the left of the figure, this is up in the thousands. On the right side is the number of AI or machine learning enabled medical devices approved by the FDA, and the scale is less than 100. So I superimpose one on top of the other, and one is just a tiny line on the bottom of the left. So there's a huge gap between the literature that's coming out for AI in medicine and what's actually making it to medical devices that are approved by the FDA. And the FDA have an amazing website where they list all of their approved artificial intelligence and machine learning enabled medical devices. This is free to look up. You don't need to log in. And I look at this every few months to see what has been approved, and they're mostly in the space of radiology at the moment. There was a systematic review done 2 years ago that showed across the world there was only 42 trials done, the full randomized control trials for AI intervention. So this is too low. And we really need to learn from the past and learn from previous mistakes that have been made, and medicinal products that were successful in phase 2 trials, but actually caused harm in phase 3 trials. So an example of this is the CETP inhibitors that were medication that increased your HDL cholesterol, increased your good cholesterol. So this sounds like a good thing, and in the phase 2 trials looking at the surrogate markers, the HDL went up. But when these were progressed to phase 3 trials, and this was published in 2007, and they actually caused harm. And the primary composite outcome had a hazard ratio of 1.25. When we looked at the breakdown of the composite, it was significant for hospitalizations for unstable angina and for death from any cause. So we have to be careful that something on the face of it, an AI intervention to speed things up, to improve things, might improve a surrogate marker, could actually do harm for patient important outcomes. There's a lot of literature grown for this in the AI space as well. So there's an excellent new journal called the New England Journal of Medicine AI, and this was a trial that came out in October called Proteus, a prospective RCT evaluating the use of AI in stress echo. This was a UK group that randomized people to decision making for stress echo, and that was augmented by artificial intelligence, or the control group was a standard clinical decision making. And the primary endpoint was an appropriate referral for a coronary angiogram. So they recruited over 2,000 patients here, and they counted how many had the correct referral for an angiogram. And there was a slight improvement in the area under the receiving operation curve, but there wasn't a difference that met their non-inferiority margin. So this is something on the face of it that should improve things, should speed things up, but when a trial was done, it actually didn't. So I gave a TEDx talk about some of these, and kind of gave a call to ARMS for more randomized control trials for AI interventions. And this retired professor in Vanderbilt called Daniel Byrne reached out to me in email. He said, I liked your talk, and he wrote a book about this exact thing. So I got his book. It's called Artificial Intelligence for Improved Patient Outcomes, and it has really shaped a lot of my thoughts around this. So if people are interested in it, you know, it's an excellent book to read. Now he called for pragmatic clinical trials here, and just to remind ourselves about pragmatic trials, it boils down to, does this intervention work under the usual conditions? So this affects things like the eligibility, the recruitment, the settings, the organization, and the flexibility. So like a pragmatic design, you have minimal inclusion criteria. You want to recruit the typical patient as opposed to the highly selected patient. And this goes back to the previous speaker. It's not a trial that a patient travels to a clinical research facility every month over 2 years, or every 6 months over 5 years, to ask them questions. Have you had an MI? Have you had a stroke? Instead, at the end of the trial, you link to routinely collected data to see has the patient had that outcome. And there's been a surge in pragmatic trials in nephrology over the last few years. There's a conference that is ran twice in Canada now, called Gardner's Grove. I presented an idea for a pragmatic hemodialysis trial like that. This is led by Professor Amit Garg, who's a world famous nephrology researcher, and he ran a trial called the MyTemp trial. So in hemodialysis, sometimes when the patient has in the middle of the dialysis session, their blood pressure drops, and this makes the patient feel very unwell. So what we often did for this is you'd slightly lower the temperature of the hemodialysis fluid, so that it would cause vasoconstriction and their blood pressure wouldn't drop. And this was a kind of an old wife's treatment. You know, there was no evidence for this at all. So Amit Garg wanted to answer this question: is a colder hemodialysis fluid temperature, will that improve patient important outcomes like mortality? So he ran a pragmatic open label cluster randomized trial in Canada. They recruited 15,000 patients for this trial, and they randomized patients to the standard temperature or to a temperature that was half a degree than your body temperature. And you can see from the primary outcome was cardiovascular related deaths or admissions, and a hazard ratio of 1.00. There was no difference at all between the two groups. So this was an example of a practice that we were doing that was actually not helping the patients at all. And this is the trial that I'm developing with Amit Garg now, called sodium for dialysis outcome reduction. And the plan for this is it'll be a pragmatic trial run in both Ireland and Canada, where we randomize patients to the concentration of the sodium in their diastolic fluid, which is an unanswered research question in nephrology. So what is needed to build a pragmatic trial infrastructure in Ireland or in the HSE? So the first thing is we need to have routinely collected data. So in Ireland, we have a lot of the medical record is on paper, but there's also a large amount of the medical record that's collected electronically now. Also, there's lots of databases that I'll go through on the next slide that have built all of the pieces for this infrastructure already. Do we need a full electronic health record to do pragmatic trials in Ireland? The answer is no. All of the parts are there already. It's kind of a joke inside the HSE. How many years away is the electronic health record? And we're always told it's 10 years away. So I was at a meeting with eHealth Ireland, and they said they're aiming for 2030 now, which is 6 years away. So we're improving a little bit. It is data linkage required, and the answer is yes. So we need to be able to know the patient in our pragmatic trial is the patient in the routinely collected data. Do we need an individual health identifier? So it definitely helps, but it's not absolutely necessary. So I just want to show hands up who's heard of the HSE individual health identifier. Okay, so maybe a third. It's third of the room as I'm looking down. So we have an individual health identifier for the last 4 or 5 years inside the HSE. And it's slowly been started to seed into all of the systems. So it started with vaccinations, and anyone who's had the COVID vaccination, your individual health identifier started there. But now it's been fed into all of the systems, like the patient management systems, the lab systems. And the amazing thing about this is now we have a very easy way of linking between the data sets we'd require to run pragmatic trials. So what do we have available in Ireland at the moment for this? Well, we have the Central Statistics Office Vital Register, and this has the mortality and data, and this is a very validated and robust database. We have the National Office of Clinical Audit. They run stroke audits. They run myocardial infarction audits. They run hip fracture audits. So if you have a stroke and you come to a hospital in Ireland, your data is going to be included on the NOCA stroke audit. There's also the primary care reimbursement service. So this is for medications. If you have a medical card or you're on the drug payment scheme, there's a record of your medications available. And finally, we have the hospital inpatient inquiry data. If you come to hospital, your notes as you're leaving the hospital are packaged up and sent to a medical coder that says that this patient with an ICD-10 code had a stroke and had a pneumonia afterwards and had an acute kidney injury. So this would be perfect for running pragmatic trials. So we've over the last two years have started to slowly build this infrastructure, and the first outcome we're going to look at is mortality. So there's a grant call that many people will be familiar with, the HRB secondary data and analysis projects. And this is a 2-year grant of 250,000, and the idea here is to answer a research question with research data that's already been collected. So Dave Kane has just left, so he missed his picture up on the screen. But Dave was the PI on the first STAP that we applied for, which is called the burden of kidney failure in Ireland from 2010 to 2020. And to boil it down, we wanted to answer a simple question: of all the hemodialysis patients in Ireland, what's their mortality rate? So this is 2024, and we don't know that. That's kind of an embarrassing thing to admit for the nephrology community. So in order to do this, we linked our national electronic health record for hemodialysis patients called EMED with the central statistics office vital registry. And we didn't have the individual health identifier at that time, so we used a probabilistic linkage. If there's a match on the first name, the surname, the date of birth, first line of the address, then you can we set a threshold for the linkage and link based on that. So we had a large group from across the HSE and all the universities to apply for this. And we wanted to be able to compare mortality in Ireland with mortality in Europe, so the European Renal Association registry. We wanted to compare with the US, the United States renal data system. But we also wanted to compare it with other diseases, and should we do that by comparing with the global burden of disease. Let's just skip that a second. So the data working group meets twice a week to work through all of these, so the linkage, the analysis, etc. And we have a very strong patient and public involvement group with the Irish Kidney Association, where the Irish Kidney Association are involved in every step along the way. So we're doing the research with the patients as opposed to the patients. So the side effect of this, and this is what I love about the STAPs, is we've answered a very important research question, but now we've also created the infrastructure for being able to link between EMED and CSO mortality for future pragmatic trials. The next outcome, I'm a nephrologist, so progression to end-stage kidney disease. And the project we did for this was through the Public Service Innovation Fund. So that's a fund from the Department of Public Expenditure. And the title of it was Automated Extraction of Kidney Failure Concepts from Clinical Notes using artificial intelligence. So in Ireland, as I mentioned, we have an electronic health record for every dialysis and transplant patient called EMED. It's a mixture of structured and unstructured data. So the structured data would be in the form of ICD-10 codes, past medical history, the medications patients on, and the lab test results. When it's in that form, it's very easy to audit quality improvement and research on it. It just looks like an Excel sheet with rows and columns. The other form is unstructured data, and the HSE is full of unstructured data. So this is a free text note where the patient comes to clinic and the doctor writes a note about them. Dear GP, I saw John in clinic today. He's a background of IgA nephropathy. His blood pressure is normal. He has no protein in his urine. We'll see him back in 6 months' time. An incredibly rich source of information, but it's not in a format that you can do audit, quality improvement, or research with. So the previous way we used to do this is ask the poor medical students to read the charts and to extract the information. And when you have the structured information extracted, then you're able to do the audit and quality improvement. So our solution to this was to use one of the first generation of large language models called BERT. So BERT is a model that's developed by Google, and everyone in this room has used BERT. When you do a search on Google, the next word prediction is all powered by BERT. So when you type the fields of, and it predicts the next word is Athenry, that's where I'm from, then it's BERT that makes that work. So BERT was trained on every word and every sentence in Wikipedia with one simple task: given a sequence of words, what's the probability of the next word? And it was trained on all that, and when it learns the probability of the next word, it learns about the structure of language, and that can be used for downstream tasks like classification, which is what we did here. Let's skip past that. So the patient pathway here is the patient goes for their dialysis. They have their note entered by the nurse. It's passed through BERT, and it goes through to a classifier to extract the structured data. So this patient has diabetes, they don't have IgA nephropathy, and they have hypertension. So now we've collected the structured data that we need for pragmatic trials. And just for time, I'm going to skip through some of this. So like most things, the machine learning, the AI, the analysis is actually the easy bit, and the hard bit is getting the approval to be allowed to do this. So we learned an awful lot here by completing the data protection impact assessment from start to finish. That took about 6 months, and even we had to modify it so the project could be feasible and done in time. So we just looked at one group. And this is where we learned about the HSE integrated information services. So this is a group inside the HSE that was set up during COVID, initially to do all the analysis related to COVID. But now the vision in the HSE is that every piece of health data collected across the HSE would eventually flow back to the HSE integrated information services. And this, in my view, is the perfect place to house the infrastructure for running pragmatic trials inside the HSE. Okay. And there's great interest in this. I was asked to talk about natural language processing inside the HSE. So lots of groups want to do this or are trying to do it. And as a side effect of this and the STAP that was led by Dave, there's a new working group of the HSE set up to develop a national end-stage kidney disease registry or data system. So that's initially for audit, for quality improvement, but we have it in the back of our heads and a future plan for pragmatic trials. And we've been funded by the HSE through Spark Impact to continue this work. So to formalise the proof of concept we did through the Public Service Innovation Fund to permanently move the EMED data into the integrated information service. And there's Dawn. Yeah. This is the HSE working with universities isn't straightforward, and there has been a lot of to and fro to develop the research collaboration agreement. So This will serve as a model, and we're happy to share this, and will serve as a future model for research agreements we'll need for pragmatic trials. So Dawn, thanks for all your help with this. The data protection impact assessment across the HSE is a much trickier beast then as well, because we have HSE hospitals and we have non-HSE hospitals. So to bring all of those together is a more complex task. And we want to treat the data validation for the registry using the machinery we have in the clinical research facility. So we want the quality of the data to be the same as in a trial, where we have our site and our coordination. So in a trial, the site is the nurse that goes down and meets the patient and fills out the case report form. In the end-stage kidney disease, the site is the hemodialysis unit where the nurse inputs the information. So the coordination in the trial is a data management group that run automated checks, manual checks and queries. And if there's any mistake, then it's sent back to site to be fixed. We're going to do the same thing where the integrated information services will be sending the message back to the hemodialysis unit to say this information is missing or this information isn't right. Okay, running out of time here, but we were successful then in a second SDAP to now link EMED with NOCA stroke. And for this one, we're actually using the individual health identifier that has been seeded to EMED, and it's going to be seeded soon to NOCA, so we'll be able to have an exact match. The future outcomes, we're applying for HRB SDAP next year to link EMED with the National Cancer Registry. We applied for the HRB Applied Partnership Award around HYPE, and we weren't successful in the first round, but we're submitting that again next week. So hopefully we'll have the connection to HYPE also. One bit we're missing though is we need GPU clusters inside the HSE to run the AI models. We applied for an SFI infrastructure grant. You know, a large group across the universities, across the HSE, and this was led by Professor Martin O'Donnell. And we got a score of 4 out of 5, but we were down on the funding list, so we're on the reserve list. So if anyone knows about a pot of money that's around, just call up to me afterwards. And if anyone's interested in helping us to build this pragmatic trial infrastructure to put all these pieces of the jigsaw together, just send me an email and I'd love to hear from you. And we can't talk about this because I'm out of time. Thanks, guys.